Welcome all to the next topic. So the next topic is umbilical cord prolapse. Again, this is a green top guideline number 50. We begin with our tagline, Master MRCOG with concept-oriented clarity. So umbilical cord prolapse. What are the key recommendations? What are the risk factors for the umbilical cord prolapse? The clinician should be aware of multiple clinical factors which increase the risk, like malpresentation, high presenting part, polyhydramnios, multiple pregnancy, etc. Antenatal detection, routine ultrasound is not sensitive or specific enough, so not recommended for predicting the cord prolapse. Okay, selective ultrasound may be considered for term breech pregnancies planning vaginal birth. Okay, so these patients you have a term breech and planning vaginal birth, you should screen these patients for umbilical cord prolapse. Okay, then what are the prevention strategies? Especially when you have unstable or transverse or oblique lie, discuss elective hospital admission after 37 weeks of gestation. In the community, patient should be instructed that she will report once the labor starts or the rupture membranes are ruptured. If it is a non-cephalic and preterm premature rupture of membrane, recommend inpatient care. Okay, and when you do ARM, avoid ARM, especially when the presenting part is high or mobile, and if necessary, ensure immediate C-section availability. Okay. What about the vaginal examination? When you are performing the vaginal examination, minimize upward pressure on the presenting part in a ruptured membrane. So when the membranes are ruptured, to see the liquor and all, don't push too high, okay, this presenting part, and avoid rupture of membrane. If the cord is felt below the presenting part, then the rupture of the membrane is to be avoided. Okay, when you feel that the membranes are intact and you are feeling the cord, avoid the rupture of membrane. Now, what is the management in labor? Cord presentation is diagnosed in established labor, usually requires cesarean section. Now, when to suspect the cord prolapse? Routine checks like exclude cord presentation or prolapse at every vaginal examination in labor, and after the spontaneous rupture of membrane, if there are risk factors. So patients with risk factors always suspect the cord prolapse and rule out the cord prolapse. Then auscultate fetal heart rate after each vaginal examination and after SROM. You will auscultate the fetal heart rate. What are the suspicious signs? Main is an abnormal FHR pattern, especially after the rupture of membranes. Immediate action is perform speculum and or digital vaginal examination if the cord prolapse is suspected. So what is the next step when you suspect? They may give you a scenario that the membranes are ruptured, the CTG is showing abnormal FHR. What will be the next step? Perform speculum examination or digital examination to rule out the cord prolapse. We are suspecting the cord prolapse. So these are the concepts which you should understand. Okay. Sometimes they ask you the next step and you discuss about the management, shift the patient for cesarean section. Read carefully what is asked in the step. Okay, and if there are no high risk situation in that particular case, if the membranes rupture, FHR is normal and there are no risk factors, the routine vaginal examination is not indicated. Okay, but high risk patients always do the per vaginal examination and FHR, but FHR you have to always check whether it is a low risk or high risk patient. Okay? The initial management of cord prolapse in the hospital setting. Cord prolapse can happen in the community setting, it can happen in the hospital setting. Now, if it is in the hospital setting, what is expected? First immediate action will be call for urgent assistance, prepare for immediate cesarean section, usually category 1 cesarean section it will be. Avoid manual replacement of the cord above the presenting part, it is not recommended. Okay, excessive handling is to be avoided because it causes vasospasm. Okay, so excessive handling should be avoided. Then relieve cord compression. Remember this, that elevate presenting part manually or bladder filling. They ask you the next step. You have done the first will be the call for assistance. Okay, first will be the call for call. Second will be avoid manual replacement, and then relieve the cord compression by manual replacement or by bladder filling. And what should be the position of the patient? Either knee chest position or left lateral head down, pillow under the hip. So these are the positions: knee chest position or left lateral head down, pillow under the hip. Okay, this is the position in the hospital setting. Okay, and Consider tocolysis if FHR remains abnormal and delivery will be delayed. So if the scenario says that these are the findings you have done up till now, this is done, this is done, this is done, the FHR is abnormal and the OT is busy, previous section is being is over and it will take 10-15 minutes to get shifted, then we might have to consider the tocolysis if the FHR is abnormal and delivery will be delayed. Okay. So the scenario, if you read carefully, you will understand what exactly they are expecting. So what is the principle? These measures must not delay definitive delivery. So definitive delivery is the main management here. Then mode of birth in the cord prolapse. Generally, it is a cesarean section. So preferred method is a cesarean section if vaginal birth is not imminent. Then it may be category 1 cesarean section or category 2 cesarean section. Category 1 cesarean section, you have to deliver the baby within 30 minutes if the FHR abnormal. If the FHR are normal, fetal heart rate is good, with continuous monitoring, you may consider category 2 cesarean section. However, when this FHR becomes abnormal, then again you will shift from category 2 to category 1. Okay, so category 2 limit is 75 minutes. Category 1 is within 30 minutes you have to deliver. Okay. Now, anesthesia. Discuss with the anesthetist. If possible, regional with the experienced team and verbal consent is acceptable for category 1. Remember, what type of consent here? If it is that severe emergency, then even the verbal consent is acceptable. You have to document the things, what was the situation. Okay. Then vaginal birth. It is possible when this patient is fully dilated, it is delivery is quick and safe and avoid the cord compression. Then breech extraction is acceptable in specific cases, like there is a second twin after IPV, after internal podalic version, the second twin is with cord prolapse, then go for breech extraction. The neonatal care, skilled newborn resuscitator must be present and always take paired cord blood for pH and base excess. Okay, so if you in the preparation, either the delivery will be by the category 1 or category 2 cesarean section, or there may be breech extraction, or there may be instrumental delivery if the patient is fully dilated, but the pediatrician should be ready and paired cord blood sample for pH and base excess we have to collect. Okay, so these options, look for these options in the of your question. Okay, then cord prolapse, how will we manage in the community? Now actually doctors will not go into the community, but the scenario may mention that the community midwife has attended such and such and she gives you the call, and then you are going to instruct certain things. So you have to read the scenario carefully and look for the appropriate answer from this particular slide. Okay, so in the community it is always a risk assessment. So when the patient comes for the booking and asks for the home birth, at that time whether this particular patient is suitable for home birth or not. Okay, even at the labor onset, whosoever the midwife is attending, whether this patient is suitable for the home birth or not, all these things are to be assessed. Okay, then immediate advice, if there is a cord prolapse, then at home adopt knee chest face down position until transfer. Okay, so if the ambulance is yet to come, then the position will be knee chest face down position. Okay, during the ambulance transfer, it will be exaggerated seams position, left lateral, pillow under the hip. Okay, so they may ask you that the midwife has attended the call and asking for the further advice. You see what information is given, accordingly you select the option. Then during the transfer will be exaggerated seams position, left lateral, pillow under them. Then transfer to the nearest consultant led unit unless vaginal birth is imminent and safe. Relieve cord compression by elevation of the presenting part manually or by bladder filling. Okay, community midwives should carry Foley's catheter and infusion equipment. So this particular advice is sometimes also expected, that generally they have the Foley's with them and infusion equipment, so they should feel the bladder, okay, and elevate the presenting part. Then cord handling is to be avoided. Avoid excessive handling of the exposed cord to prevent vasospasm. Okay, so this is what is the management in the community. Is it clear to all of you? Dr. Sinchana, Dr.
Yes.
Indra? Yeah.
Yes.
Yes, sir.
So cord prolapse around the time of threshold of viability, if it is a extreme premature 23 to 24.6 weeks of gestation, The management option, you can discuss the expected management because it is a threshold of viability. Okay, discuss the expected management in this gestational age. No evidence supports replacing the cord into the uterus at or before this stage. Counseling advice for both continuation and termination of the pregnancy. So it is a shared decision making. And delayed cord clamping, what does they say? They are saying consider if newborn is stable and prioritize immediate resuscitation if the baby is unwell. So it will depend upon the stability of the baby. Okay. These are few clinical governance points. We have to talk to the relatives, explain the events, whatever have happened. Then you have to train the staff. Then we have to go for incident reporting and documentation. These are for part 3, not for part 2, but just remember. So whatever we have seen up till now was regarding the cord prolapse were the key recommendations. Now we will go into the details of this. So what is cord prolapse? It is a cord prolapse. Umbilical cord descends through the cervix alongside, that is occult cord prolapse, or the past overt cord prolapse presenting part with the rupture of membrane. Okay, so the umbilical cord descends through the cervix alongside, that is the occult, or it may be overt when it is past the presenting part with rupture of membrane. Then what is cord presentation? Cord is between the presenting part and the cervix with or without intact membranes. Remember the incidence, the 0.6% is the incidence for cord prolapse, 0.12, or sometimes they will give 1 in 200. Okay, so that is 0.5% comes. Okay, overall 0.1 to 0.6%. Breech presentation will have 1% incidence. Okay, so cephalic will have half of that. Okay, half higher in multiple gestations. Then impact on outcomes. Features in parental mortality review. Parental mortality is 91 per 1000. Okay, made adverse outcomes will include prematurity, congenital malformation, birth asphyxia, etc. Pathophysiology. Cord compression, umbilical arterial vasospasm leads to the impaired blood flow to and from the fetus. Okay, so now what are the general risk factors associated with the cord prolapse? Multiparity, low birth weight, preterm labor, congenital anomalies, breech presentation, transverse, oblique, unstable. These all factors we know. Okay, then procedure related will be ARM with high presenting part, vaginal manipulation with ruptured membrane, external cephalic version, internal podalic version, stabilizing induction, intrauterine pressure catheter insertion, or large balloon catheter more than 180 ml saline for induction if it is used, that can displace the presenting part and will permit the cord to come down, and manual rotation of the fetus. So these are the clinical conditions in which there can be cord prolapse. Key points: around 50% of the cord prolapse cases follow obstetric intervention. So obstetric, we have just seen these were the conditions associated with the procedure related, and how many? 50% of the cord prolapse will be associated with this. Risk increases when the presenting part is not well applied to the pelvis or lower uterus. Amnio infusion risk is unclear. Okay, so these are a few points which are important. Detection of cord presentation antenatal. Routine ultrasound is not recommended. This we have seen already before. So same thing. If it is a breech presentation, then weekly transvaginal scan for breech after 36 weeks with cesarean section for persistent cord presentation. Reduce cord prolapse to 0 in 10 years. So if it is a breech presentation, then we can screen weekly after 36 weeks of gestation. Okay, and this will help women to make a choice regarding the vaginal breech birth. Okay. Now coming to the prevention of cord prolapse. When we have abnormal lie, that is transverse, oblique, unstable, consider hospital admission around 37 weeks of gestation. Advise urgent presentation if there is a rupture of the. If it is a non-cephalic with PPROM, recommend inpatient care. Okay. Avoid ARM if the presenting part is high, mobile, or cord is felt. If necessary, ensure immediate cesarean section capability. Okay. Minimize upward pressure during examination, interventions in ruptured membrane. Cord presentation in labor will require cesarean section. Labor and rupture of membrane with abnormal lie, usually immediate cesarean section. Decision depends upon the gestation. Okay. What does the NICE say? Assess engagement before induction. Avoid ARM if the head is high. This is what is the NICE recommendation. We have to assess for engagement before induction of labor and avoid ARM. Okay. So these are actually many points we follow in our day-to-day practice. So when to suspect the cord prolapse? Check for cord presentation or prolapse at every vaginal examination and after SROM if risk factors are present. So if the risk factors are present, we have to do the vaginal examination okay, in labor and after SRM, auscultate FHR after every vaginal examination and after SRM. Now, what are the suspicion triggers? If there is abnormal FHR soon after rupture of membrane, especially bradycardia or variable or prolonged deceleration, high presenting part or polyhydramnios after rupture of membrane. Then diagnosis will be prompt vaginal examination or speculum examination if suspected. No routine vaginal examination after SROM if FHR is normal and there are no risk factors. Okay. Now, optimal initial management of cord prolapse. So, hospital setting we have already discussed. It is emergency cesarean section, that is category 1 cesarean section when the patient is not fully dilated. Avoid manual cord replacement to continue the labor. Unnecessary cord handling is to be avoided and delay in delivery to be avoided. Prevent cord compression by elevating the presenting part manually or via bladder filling 500 to 750 ml of via Foley's. Okay. And that has to be emptied if it is a vaginal delivery. Okay, remember this. Maternal position will be knee chest or head down, left lateral with pillow under the hip. Consider tocolysis, terbutaline 0.25 or 250 micrograms subcutaneously if FHR are abnormal and delay is likely to happen. Okay, then cord care, avoid manipulation. Wrapping in the warm saline swabs not proven to be beneficial. Okay, what does the evidence say? Bladder filling, manual elevation linked to good outcomes and more effective if diagnosis to the birth interval is prolonged. So this is what is the concept which they are likely to test from the scenario. Okay, so they will expect you the bladder filling or manual elevation of the presenting part. Now, cord prolapse, if further, if it is a vaginal birth and that is imminent, then you go for expedite the vaginal delivery, maybe operative if needed, and avoid cord impingement. If vaginal birth is not imminent, then category 1 cesarean section or category 2 cesarean section, depending upon the FHR. Abnormal CTG, you will go for category 1 cesarean section, and normal FHR, you will go for category 2. And you will convert it to category 1 if the FHR abnormality arises. Anesthesia, regional, if there is an expert person and the cord compression is relieved, then you go for regional anesthesia. Otherwise, GA if it is urgent and safe. Okay, so it will depend upon whether we have relieved the cord compression or not. Okay, then special cases we may go ahead with the breech extraction. All births, the neonatal resuscitation team paired cord blood gases for pH and base excess. This also we have already seen. Okay, outcome CS reduces perinatal mortality versus non-imminent vaginal birth. If birth is imminent, outcome is similar. Okay. Decision to delivery interval. Shorter DDI linked to the better neonatal outcomes. Aim within 30 minutes for cesarean section and within 20 minutes for operative vaginal delivery. So if you are anticipating delivery will not be within 20 minutes, then we might take the decision of a cesarean section. Okay. Instrument of choice will depend upon the operator's skill. So if there is a vaginal birth which is imminent, expedite vaginal delivery. If vaginal birth is not imminent, category 1 or category 2 cesarean section along with the depending upon the fetal heart rate, breech presentation, breech extraction. So this is what is the key message. The anesthesia of choice, regional with expert provided the manual replacement is done. Otherwise, GA. Okay. All births after the cord prolapse, neonatal resuscitation team, and this all we have seen. Okay. Then coming to the summary of optimal management in the community setting. Okay, risk assessment. Midwife should assess the risk of cord prolapse before approving home or low resource birth, and again at labor onset. If cord prolapse known at home, then advise knee chest face down position until transfer begins. Okay, knee chest face down position until transfer begins. During ambulance transport, seams position, left lateral with pillow under the hip. Hospital transfer to the nearest consultant led unit. Relieve cord compression by bladder filling or by manually because they are supposed to carry the Foley's catheter and fluid. Okay. Then cord handling to be avoided. Minimal contact to prevent the vasospasm. Warm saline swabs around the cord are not proven beneficial. Perinatal outcome in the community setting 10 times more higher when the cord prolapse occurs outside the hospital. So perinatal mortality is 10 times higher if the situation happens in the community. Okay, so these are the and key preventing factor during transfer is maintain presenting part elevated to reduce the cord compression. Then Should delayed cord clamping be used after cord prolapse? DCC can be considered if the baby is uncompromised at birth. Okay, immediate resuscitation takes priority if the baby is unwell. Term infants, DCC may be beneficial, especially in settings with poor nutrition. Okay, preterm less than 37 weeks, DCC up to 180 seconds linked to fewer transfusions and better stability. Okay, so generally they are not asking in the cord prolapse DCC. We have the next topic of this. Any one of you wants to go ahead with few questions, doctor? Whatever we have learned. Yes. Anyone?
Okay.
Yeah.
Yes, sir.
Yes. Start.
29-year-old primary gravida at 39 plus 2 weeks in active labor at 5 centimeter dilatation, presents with sudden deceleration in fetal heart rate to 80 beats per minute following artificial rupture of membranes. Vaginal examination confirms cord prolapse and the presenting part is high. So
Yeah.
for each scenario of cord
Yeah.
prolapse during
These
labor,
are yeah
select the most
appropriate mode of birth.
appropriate mode of birth from list above.
So first question, you have understood. Shall I show the options?
Yes, yes.
This,
Yes, sir.
Option A, immediate category 1
A,
C section.
immediate
B, category
category
2
1
section with continuous monitoring. C, operative vaginal birth. D, expected management. E, emergency research. This immediate category 1 cesarean section.
Yes, sir.
okay. Next.
A.
Yeah. Next.
A 34-year-old multiparous woman at 38 plus 5 weeks with spontaneous rupture of membranes during labor. Corporal axis confirmed she is 8 centimeter dilated with a normal CTG and fetal head at station 0.
Um,
She can be put at corporal axis with normal CTG.
Did the findings, everything normal CTG, 8 centimeter
8
dilated,
centimeter.
station is at 0.
Expected management. But expected management.
Operative vaginal delivery, sir.
Do you expect this patient will deliver in 20 minutes?
So
She
multiparous,
can deliver multiparas 8 centimeter dilated
multiparous.
0
8
station.
centimeter.
Let's see what is the option. They have not given the answer is not given, but I think this should be the category 2 cesarean section because the
Okay.
FH is normal. Okay.
Okay.
Then next.
A
Next.
26-year-old G2P1 at 37 plus 4 weeks confirmed cord collapse during second stage. She is fully dilated and fetal head is at plus 3 station.
So here, what do you think? She is in the second stage. She is gravida 2 para 1. Okay. She is a
Yes.
multigravida, fully dilated, confirmed cord
Yes.
prolapse, and station
Yes.
is plus 3. Don't you think here the operative?
She'll deliver.
Yeah, no,
Vaginal
here
delivery at
also.
full dilatation.
But what about the FHR they have mentioned? Fully dilated,
They're
but
not mentioned.
Not
no, but
mentioned FH.
expectant management we have not discussed anywhere.
Hmm.
See, if you see
Yes, sir.
all the slides, they are talking about expected the delivery operative if needed. Okay, then
Yes.
operative in the means operative vaginal delivery. Okay,
Yes.
head load delivery quickly possible. We are going to
Hmm.
go ahead with instrumental delivery.
C-section.
No, no, here
Yes.
Operative
instrumental
vaginal
delivery.
Vagina.
delivery at full
Station is
dilatation.
plus
Op-
3. No,
operative vagina.
operative vaginal delivery. Okay, either forceps or vacuum. Last we have seen the instrument of choice will depend upon the surgeon. Okay, comfort of
Hmm.
the surgeon. Next.
A 31-year-old woman at 40 plus 1 weeks, twin pregnancy, second twin in transverse lie after first twin delivered. Cord collapse occurs after rupture of membrane.
Very simple here, straightforward.
Section immediate
Why section?
Immediate
category 2 sec
Why category 2
category 2
section?
sec.
Why category 2 section? Why not breech extraction?
breech extraction. Okay.
No?
Okay.
We'll go ahead with the breech extraction now. 31 year with 41. First vein is delivered, second vein is in transfer slack. Okay.
Okay.
So
Yes, sir.
already fully dilated. So breech extraction is possible. That also we
Yes,
have
sir.
seen.
Emergency B section.
Emergency breech extraction.
That finishes our topic. Thank you.